Good morning, everybody. Thank you to the organization for this invitation to present today. It's an honor to be part of this British-Ukrainian symposium on anesthesia. My name is Alexandra Schyns, and I'm from the Netherlands, where I am an obstetric and general anesthesiologist. The title of my lecture is Safety of Labor Analgesia, a case, because rather than presenting a dry overview of risks and statistics, I have chosen to present a case which happened in real life in my hospital a few years ago. The World Health Organization's intrapartum recommendations on safe labor and delivery place labor analgesia among the pillars. This is a position which was recently affirmed by the World Federation of Societies of Anesthesiology. Every woman in labor has a right for pain relief. Anorexia labor analgesia is one of the most commonly performed anesthetic procedures worldwide. It's up to us to make sure it is provided safe, and we should always remain prepared for potential complications, even when the optimization, delivery techniques and the drugs used are safe and gold standard. Which analgesic options are there during labor? Beyond neuraxial techniques, systemic opioids are widely used, particularly in settings where neuraxial analgesia is not possible or available. Petidine has been used for decades, but it has limited efficacy, and there is a risk of neonatal accumulation of norpetidine. Remifentanil PCA has gained significant popularity in recent years, but it would take a lecture on itself to talk about remifentanil safety. And then, of course, there are many non-pharmacological options, for instance, nitrous oxide, TENS, and water injections, which I don't put in the slides, where the water is injected in the back of the woman in labor. It's thought to provide limited analgesic efficacy for back pain during labor. But what about the fetal safety of all these various techniques? What do we know? And that's often the first question our patients ask. Is it safe to have labor analgesia? Is it safe for the baby? Well, the key principle in this is placental transfer. All systematically administered drugs cross the placenta to some degree, and it depends on lipid solubility, molecular weight, protein binding, ionization, placental blood flow, amongst some of the factors which are affecting placental transfer. And then, of course, if you give neuraxial local anesthetics, they enter the systemic circulation only very low, and there is minimal fetal exposure. This is higher with systemic opioids, which are often highly lipophilic and pass the placenta very easily. Well, often the way the analgesia affects a baby is described by the fetal heart rate changes. And epidural and spinal anesthesia has shown in the past, with high concentrations used and opioids added, that acute fetal bradycardia could happen either following maternal hypotension or related to a prompt analgesia and changing the adrenergic balance of the laboring woman in stress. Remifentanil and petidine have been associated with fetal heart rate changes as well. And then, of course, with systemic opioids, there is a risk of respiratory neonatal depression. But with the remifentanil currently used, it's only 7% of neonates who require supplemental O2, and in a very short period, because the remifentanil is eliminated very quickly in the circulation of the neonate. Well, we should look at the benefits of labor analgesia for fetus and neonate as well, not only for the mother, because it's a myth that unmodified labor is safe for the baby, because untreated pain causes maternal hyperventilation, there is a catecholamine surge, and there is a metabolic acidosis risk. These factors are all harmful for the baby. Epidural analgesia blunts the stress response and has been demonstrated to improve fetal outcomes, better APGAR scores, higher umbilical artery pH, and a better neonatal acid-base balance, especially compared to systemic opioids or to no analgesia at all. So when we discuss the risks of labor analgesia, we must always realize there are also risks of inadequate pain relief when the mother is suffering and in pain. Epidural analgesia is considered the gold standard. The current provision, though, differs very much between the various countries, related to healthcare organization, culture, available means, money. In the past, neuraxial analgesia has been associated with various complications, but due to optimizing drug concentrations, drug combinations, delivery strategies, these have minimized. And today I will focus on the maternal safety of labor epidurals, and especially related to a high block. And indeed, there is a matter of maternal safety. This publication, following the NAP7 report, which is a national audit in the UK on cardiac arrest related to anaesthetic care. This report was published in 2024 and looked specifically at the data associated with obstetric anaesthesia. And it provides us with insights how often cardiac arrest happens in obstetric and anaesthesia. Well, there were 28 cases, 3% of all cardiac arrest in the NAP7, and this relates to 8 in 100,000 deliveries. And 12 of these cases were related to neuraxial anesthesia for caesarean section, 8 were related to obstetric surgery, and 2 were related to neuraxial analgesia during labor. So that's a very low number. But still, looking at these data, hemorrhage, of course, was a very important cause, especially if underestimated and inadequately handled. Then there was the neuraxial anesthesia was really the leading anesthetic cause due to high block and bradyarrhythmias. And what NAP7 showed us, there were no cardiac anesthetic arrests from failed airway or RAMI fentanyl analgesia. But anyway, our job is to be prepared for emergency in all the procedures we do, and this is the same for labor analgesia. Another paper which was published, which also was more or less associated with a high neuraxial block, came from the Netherlands by Ingrid Beenakkers and Oscar van der Bosch. They found in a national registry comparable to the NAP7, NETOS, they found 5 cases of high neuraxial block which required a tracheal intubation in a 2.5 time period. And one of these cases was associated to labor epidural analgesia, which happened in the labor ward without any association with spinal anesthesia. So as far as these numbers are concerned, I'll move to my case now first. The case concerned a woman who had labor analgesia in my hospital. It was provided by our resident. The woman was healthy. It was her first pregnancy, but she was induced, her labor was induced because there was a hypotension starting to surface, for which the obstetricians were worried that it would develop into preeclampsia. At 11 in the morning, she was given the epidural analgesia by the resident, and actually the first bolus of 5 milliliters of ropivacaine and sufentanil was followed up by continuation with PIEB. Within 10 minutes, the patient was satisfied, but the vital signs were normal and the CTG was normal, and after 15-20 minutes, she was sent back to the labor ward. So once she returned to the labor ward, oxytocin infusion was started and the woman was extremely comfortable. But 2 hours later, she reported bilateral numb and tingling hands. So the obstetric resident called me, I was anesthesiologist in case, so I advised her to stop the programmed intermittent epidural bolus. So we stopped delivering any more neuraxial analgesia local anesthetic. And I sent my resident immediately to the delivery unit to see what was going on. And she noted that the sensory block was satisfying at level thoracic 8. The vital signs were stable. There was no motor block at all, but the woman was still complaining of numb and tingling fingers. So we advised to follow up the vital signs very carefully and the neurological changes. And the resident went once back to look at the patient again. But what happened is half an hour later, that the patient started to complain about a metallic taste in the mouth and she became a little bit sleepy, sluggish. But her vital signs continued to be normal. So I was called again and this was definitely not okay. Within 1 minute, I was in the labor ward, 1 floor, a staircase away, but I made sure I got there very soon and I alerted the resuscitation anesthetic team, which came soon thereafter with all the equipment to provide emergency anesthesia and whatever. So once I was there, the vital signs were still normal. The contractility of her hands were normal. She could move her legs, but she was still having these numb feelings. And she was indeed sluggish, and she still had this metal taste in her mouth. I didn't test at that moment the sensory level. That's one thing I forgot, because I was worried about the following. This is a differential diagnosis which was coming up in my head, but to be honest, I thought, of course, of local anesthetic toxicity. And while the HELP as the vital signs were normal and there weren't any changes in blood pressure, I wasn't so sure about HELP at that time. The abnormal position of the catheter was in the back of my mind. And of course, you should consider neurologic pathology. But there was no left-right difference. So this was one of my secondary diagnoses which I had in the back of my head. But since there is the thought of local anesthetic systemic toxicity, a real risk which is associated with the work we do in the provision of local anesthetics to the human body, I want to spend a little time on describing what's going on. And of course, most of you will know that if we accidentally inject intravascularly an excessive amount of local anesthetics, we can get complications, and especially with bupivacaine, which is very strongly bound to the sodium channels of the heart, there is a risk of cardiac toxicity. And levobupivacaine and ropivacaine, the one we used, there it's relatively smaller. And which are the symptoms? Normally central nervous system symptoms occur first. And these fitted the symptoms our patient was reporting. Perioral tingling, metallic taste. But we didn't observe any progression to seizures, but we had not really loss of consciousness, but we were having a problem with the consciousness of the patient. We didn't have any cardiovascular symptoms. So we acted accordingly. What do you do first to prevent local anesthetic systemic toxicity? I should start with this first. If you inject local anesthetic in the epidural catheter, always aspirate first in the first few periods when you do it manually. And in the past, we used test doses in which we thought we could see tachycardia response if the catheter was intravascular. But this is very unreliable during labor, and the use of test doses has been forgotten mostly at least in the most units in my country. As we use very low local anesthetics concentrations, the not having any analgesic effect of the delivered drug shows us towards a malposition of the catheter without needing a test dose. What is the treatment protocol? Well, of course, you have to stop injection. That's what happened. We stopped the PIAB. Make sure if you have all tools available to secure the airway if needed. And to treat local anesthetic systemic toxicity, intralipid is used. 1.5 milliliters per kilogram bolus of 20% intralipid, followed by an infusion. Protocols on this can be found online. If there is seizures occurring, benzodiazepines can be preferred, and avoid propofol. And if there is cardiac arrest, of course, start resuscitation and use small incremental dose of adrenaline. Well, what we did to include last, I injected intralipid intravenously, and it gave no improvement at all. So this was quite unexpected. But within 10 minutes, I realized I had to go to my next strategy and my next suspected dose. The drowsiness made me think of intravenous opioids, sufentanil. So I started with giving her naloxone within 10 minutes. And the patient was immediately responsive and awake. And this reversal tells us that opioid toxicity was playing a significant role. But where was the sufentanil coming from, and why at this dose and timing? This brings us back to the catheter position. An abnormal epidural catheter position, either spinal or subdurally, was now my leading hypothesis. If the epidural catheter had migrated into the intrathecal or subdural space or was placed in those spaces, epidural doses of sufentanil would result in much higher CSF concentrations than intended, which could explain the opioid toxicity picture. Well, if you have a high spinal block or a total spinal block, that's when you inject the local anesthetic and the opioids into the intrathecal space, and you get a block beyond T4, which actually will result in respiratory compromise. And if the block goes higher even, you can end up with a total spinal one, where the brainstem becomes involved, and apnea, cardiovascular collapse are the next consequences of the intrathecal local anesthetic spread. The risk factors are when you give a full epidural dose in the intrathecal catheter, which you don't know which, of course, is in the intrathecal space. And it's also when there is an unintended dural puncture, there could be an extensive block of epidural dose migrating intrathecally, which would explain some of the symptoms in this patient. So that might have been also the issue, but as the symptoms started 2 hours after the initial epidural, this seemed less likely. What's the clinical presentation of a subdural catheter? Well, if you have a subdural catheter, you see, I'm too fast. I'm still with the intrathecal catheter. Please, apologies. Accept my apologies. The clinical presentation of a spinal catheter is when you have this rapidly ascending sensory and motor block, and you get dyspnea and you get loss of consciousness in severe cases. And the management is, like always, call for help. Make sure you secure the airway. Make sure you prevent cardiovascular collapse. And left lateral tilt, fluid resuscitation when needed, and talk to the patient if she's conscious, reassure her what's happening, and take next steps if needed. But actually, this wasn't the case. I had the feeling I was more suspecting that my catheter was in the subdural position. So what is a subdural space? Well, this is not really a space. It's if you inject fluid through a catheter, which is located between the dural layers and the arachnoid membrane, you can cause a virtual dissection. So these drugs you inject in this virtual space which you are creating, they spread unpredictable and often in a disproportionate manner. And actually, this was a diagnosis that best fitted my patient. A subdural positioned catheter, a patient who had a subdural positioned catheter who received PIEB doses over more than 2 hours with the opioid component gradually accumulating, would explain the rapid reversal by naloxone. Now, this is how a subdural position of an epidural catheter looks like. This potential space is created by injecting fluid, which causes a dissection. And the diagnosis we started to work with that. Well, what are the symptoms? Why was I, in the end, convinced that my catheter was subdurally positioned? I had seen it before, not often, but it's important to recognize. But if you've never seen it before, you should be always aware of it because it happens more often than we think. And if you see which symptoms are associated with subdural injection of our mixture, of our epidural mixture, you see the prevalence of the various symptoms is quite varying, especially the serious side effects often don't occur. Bradycardia or hypotension occur in less than 30%, cardiac arrest in less than 4%. And actually, 40% of patients, no more than 40% of patients have any significant cardiovascular depression. And here, the last in row, you can see the altered mental status, which has been described in 10% of patients. Now, at placement time, what could we have seen? Hoffman published a very extensive review of subdural catheters a few years ago in Regional Anesthesia and Pain Medicine. And they analyzed 70 cases, and these cases were confirmed with a fluoroscopy that there was a subdural position of the catheter afterwards. Well, the various cases showed that in most cases, there was a negative CSF aspiration during placement. There was no specific response on a test dose. There was a slow onset of the epidural in more than 70% of patients. And 20% of patients had quite a faster onset, faster than expected. And more than 10% had indeed delayed symptoms of delayed deterioration. Now, if you look at the motor block distribution of patients with a subdural catheter, you see there is a mixed presentation. Also, upper extremities can be involved. And also, 35% or more of patients did have no motor block at all of these 70 patients Hoffman described. And if you look at the sensory segmental distribution, there were actually many patients who had excessive or high distribution sensory. Patchy distribution is described in 30% of patients. Restricted distribution has been observed, but in more than 90% there was an abnormal sensory distribution. So the moment you have an abnormal segmental sensory distribution, you should always be aware of a subdural catheter position. What are other symptoms of a subdural catheter? In our patient, we saw tingling in the fingers, hands, and around the mouth. We had this increased drowsiness, and indeed we did not have any changes in vital signs. And it's unpredictable how it presents fast or delayed, and this is why the diagnosis is often missed. But once you have seen it or thought about it, the pattern becomes recognizable. And what should you do if you suspect your subdural catheter is epidural? Well, to begin with, you should stop the epidural infusion, like the obstetric resident did immediately. And early detection by close monitoring is key. So I stayed with my patient, the whole emergency team stayed nearby in the hall, and we checked vital signs, we checked the development and changes of motor block, of analgesia level, sensory level, and we actually were discussing, let's put her a little bit in anti-Trendelberg, and what should we do in case of a resuscitation. This was a moment that actually we were discussing with the obstetricians. We cannot sit here and watch and see what happens because it still can ascend further. We can suddenly come in a resuscitation situation even at this time. So we decided, let's go for secondary C-section. First, of course, the lady had a hypotension anyway, and the obstetrician didn't want to wait for more complications. But with the subdural catheter and with subdural fluid in unexpected places, any spinal or epidural anesthesia was impossible. So we discussed with the patient and her husband that it was going to be general anesthesia, and we did as much as we could to provide a safe and a mother and child friendly anesthesia, with the father being with her in the operation room all the time. While she was asleep, we put the baby on her chest, and the baby did perfectly fine, and so did the mother. She recovered uneventful, and we made an appointment for her to speak about what had happened and how we could analyze further. And we said, and she felt very secure if we could see if there were any abnormalities in her spinal canal. So we did an MRI, and this turned out to be completely normal. We forgot something though. What we did forget, we forgot to look for fluoroscopy confirmation. We should have left the subdural catheter in place, and after a few hours, once there was complete resorption of all signs and symptoms, we should have done a radiologic investigation. This would have confirmed our diagnosis. Now, Hoffman was quite thorough in this article, and I advise you to look it up. She even made a sort of decision algorithm, what to do and how to think of a possible subdural position. Well, if there is an excessive immediate distribution, it's often obvious that there is a spinal catheter placement. But there is a restricted distribution of dermatomes, and it takes a long time, or when there is actually no onset of block at all, you might as well suspect the catheter is subdurally instead of subarachnoidal, even though there was a CSF positive aspiration test. Well, if the catheter was presumed epidurally and there is an excessive spread with motor sparing, then there is a high risk of subdural position. And if there was a restricted dermatomal distribution and the delayed onset without any motor block, then the risk of subdural position is actually quite high. So I advise you to look this scheme up and read about it, because it's all interesting material. And more than that, if this happens, even though unintended, it's a immediate consequence of what we do as anesthesiologists, which can eventually result in severe outcomes. Luckily not in this case, but only because everybody involved was beware of subdural catheter placement. Neuraxial labor analgesia is safe, but we should perform it safe, we should monitor it safe, and we should follow it up appropriately and safe. We should remain vigilant, always, and never be afraid to ask immediate help when needed. Thank you very much. I'm happy to take any questions.